This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, a senior attending neurosurgeon.
And I'm Dr. Alara, a research fellow. Today, we're looking at a fascinating new study from Neurologia medico-chirurgica, published in 2026, titled Surgical Management Strategy for Large Cystic Vestibular Schwannoma, based on the Cyst Classification.
This is a topic that hits home for many of us in the OR. We often think of vestibular schwannomas as these slow-growing, solid tumors, but the cystic variants are a different beast entirely. Alara, what was the primary focus of this study?
The authors looked specifically at large cystic vestibular schwannomas, which they defined as having an extrameatal diameter of greater than 30 millimeters. They included 19 patients who underwent microsurgical resection and focused on how the morphology of the cyst, its location and wall thickness, actually dictates the clinical course and the surgical strategy.
And that distinction is vital, because as the paper notes, these cystic tumors often grow more rapidly and adhere much more strongly to the facial nerves and the brainstem compared to their solid counterparts.
Exactly. To categorize these, the researchers used the Picarillo et al. Classification system. They divided the tumors into two main types. Type A tumors are those with centrally located, thick-walled cysts. Type B tumors, on the other hand, feature peripherally located, thin-walled cysts.
That classification proved to be a significant predictor for preoperative risks, didn't it?
It did. One of the most striking findings was the incidence of sudden clinical deterioration. The study found that patients with type B cysts, those peripherally located and thin-walled, were significantly more likely to experience sudden clinical deterioration during the preoperative waiting period.
That's a critical point for the residents listening. When you see a large type B cystic schwannoma on the MRI, watch and wait might be a dangerous game. The paper suggests these patients may require early surgical intervention because of that risk of rapid decline.
Precisely. And moving into the operating room, the study emphasizes that the thickness of that cyst wall is the key factor in deciding how aggressive to be with dissection.
Right. We always aim for a total resection, but with these cystic variants, the forceful dissection of a thin wall can be a recipe for disaster for the facial nerve.
That's exactly what the data showed. In cases where the thin cyst wall was firmly adhered to the facial nerve or the brainstem, the authors applied a conservative surgical strategy. Instead of risking a nerve injury, the wall was intentionally left in place, rather than attempting forceful dissection.
And what were the functional outcomes of that conservative approach?
The trade-off is very clear. By leaving the adhered wall in place, they achieved excellent facial nerve preservation. However, this approach did relatively decrease the overall extent of resection.
It's that classic neurosurgical balance, function versus extent of resection. In the context of the facial nerve, especially in these large tumors over 30 millimeters, most of us would argue that preserving the nerve is the priority, even if we leave a thin layer of the cyst wall behind.
The study backs that up. It concludes that it is essential to adapt the dissection strategy according to cyst wall thickness to achieve that optimal postoperative preservation.
So, to summarize for our colleagues, type B cysts, peripheral and thin-walled, are the high-risk ones. They grow fast, they can cause sudden deterioration, and they stick to the facial nerve. If you find yourself struggling with a thin wall that won't peel off the nerve, the conservative route is supported by this evidence.
Precisely. Know your cyst type before you scrub in, and let the wall thickness guide your dissection.
Excellent. That's all the time we have for today. Thank you, Dr. Alara, for breaking down this study.
My pleasure. We'll see you next time on the Neurosurgery Hub.